Okay, we'll make a start. Good morning, everybody. I can see the numbers are going up there on the control panel. So welcome. Thank you for joining us this morning. We're thrilled to have so many people registered and here to take part in this conversation about prevention in times of crisis. I know from looking at the list of people who've registered, we've got some familiar faces as well as some new ones. So our team, and I'm going to hand over to John and Joe in just a moment, has been working with local authorities and voluntary and community sector across a series of different projects for the last 5 years now. Some of you might remember the Enabling Social Action Programme that we ran with DCMS. Others might have been part of webinars that we ran during our COVID-19 research, the MOVE project, and some of you I think are brand new. So welcome to everybody. We think that this is a really important time to bring people together who are trying to embed strengths-based prevention during this quite difficult climate. And so we're excited to have so many of you here from different sectors and different regions. So I'm just going to paste the agenda into the chat, so hopefully you can all see that. And so shortly I'm going to pass over to John and Joe, who are going to share some of the findings from our latest research projects around strengths-based prevention, and hopefully some of you will have already had a chance to see our short policy briefing that we've been sharing from the LAC project, and our full report launched on Monday, so that has also been shared with participants. And then after John and Joe have spoken, we will hear from our panel around 10:20. We've got a fab panel with representation from local authorities and from the voluntary and community sector as well. And then what we'll do is we'll have a few kind of quick clarifying type questions after each panelist, but we'll save most of the questions, the kind of big discussion questions, for the Q&A, which we're going to start at about 11:10. And Joe is going to talk a bit more about this at the end, but we're really hoping that today is going to be the start of a kind of revival of our old network. We feel that there is great value in creating a collaborative space for practitioners and policymakers to come together and share important learning. So after the Q&A, we're going to use a Jamboard so that you can all feed in as to what you might like to get out of that. And so I'm going to do a super quick demo and show how that works. So,
Harriet, also we'd encourage people to fill out the Jamboard as the session goes on as well. If you feel so inspired to do so, that would be brilliant.
Yeah, absolutely. I'll share the link after I've done this little demo. So this is what the Jamboard looks like when you open it. So you've got this panel down here, and you can click sticky note, and then you can just pop in, I would like to share learning with other policy makers, and then press save, and then you can move it around, and there's a few other kind of features you can do. Can you do circles, text box? So if you use the little sticky notes and kind of stick on the board and move them around so they're not all bunched together, and then we'll sort of take a look at that together at the end. Okay, so I will stop sharing my screen. So a few housekeeping points before we get started. So our panelists are visible and audible, but because of the large audience and because of the platform that we're using, our audience is not. So you can participate using the Q&A to ask questions, and you can also use the chat function to introduce yourselves and to discuss and comment. So we're limited by the platform we're using, so we can't have a more open forum, which is a shame, but we want the Q&A to really be led by the audience. So please submit your questions. My colleague Ben will be organising them, and then we'll field them to the panelists. We're hoping to have a good 40 minutes for questions. And in future events, we'll try and create that space so you can unmute and share your video, so the discussion is a bit more dynamic. My colleague Katie is going to be watching the chat, so if you have any kind of technical questions or questions about accessing reports or the network or anything like that, she'll respond to you on there. We are recording this session, so our panelists have agreed to be recorded. We won't be kind of promoting the recording, but we will share it with people who haven't been able to make it, who've asked for it, and we'll share it with you all via email after today. And then lastly, we will be tweeting about today's webinar. We're going to be using the hashtag prevention webinar, so please do join in online if you are into that. And I will now pass over to Joe and John.
Thank you very much, Harriet. and thank you everybody for coming along today. We're going to kick off with just a little bit of a brief overview of the work we've been doing and some of the key themes to sort of set the scene for the session today. So I'm just going to share my slide with you here. Right. So, because that's in the way. So what we want to do is just talk a bit about the emerging themes and the issues that we come across as we've been working in this area. And Joe's going to talk a little bit about some of the findings and implications and where we want to go after that process. As Harriet was saying earlier, we feel that we are, in many ways, prevention is facing a significant crossroads. On one hand, we're hearing it regularly situated as a core solution to the ongoing crisis in local authority services, and specifically within adult social care as a key area, as the way forward, and the prevention needs to be the thing we need to be looking towards. We can't keep doing what we're doing. However, at the same time, we're constantly facing a situation in which the capacity of services to actually implement and embed prevention is being severely weakened, both because of the costs. Excuse me, Joe's just unshared the slides. Where the hell have you put those?
I don't know, they're down here.
There we go. Never let someone else touch your screen, right? So it's been severely weakened by the uncertainty around the benefits that prevention brings, actually how we capture those benefits, and due to the sort of pressure of trying to prove that you've stopped something that hasn't happened from happening. At the same time, we're seeing an escalating crisis in social care and an escalating pressure on the investment in all sorts of service provision, which is putting massive pressure on abilities of local authorities to invest in prevention and in those circumstances. The current process through the cost of living crisis, the pressures of resourcing crisis support have constantly meant that both resources and capacity to deliver prevention have been putting under significant strain. And so for us, this is the vicious circle, as the ADAS report showed, vicious circle of having insufficient funds to be confident they can meet all their statutory duties, while being unable to release funding to invest in approaches that might reduce the number of people with higher needs in the future. So what we describe is this prevention paradox in many situations, as we've just said, situated as a potential solution, but capacity to engage is being restricted by uncertainty in two key areas. One is the budgetary restrictions, limited budgets to commit to prevention, pressures of meeting statutory service provision in all other areas, meaning that often when the discussion comes to the head, the issue about how to put more into prevention always sits behind that issue of can we meet our statutory duties. At the other side of that, uncertainty around the sort of data that's coming out. We're still struggling with a limited evidence base to highlight the value and impact of prevention. And in many cases you hear people say, we know it works. And we do seem to know it works. The gut instinct is we know that this is the way forward, but how do we evidence it that convinces those people who are controlling the purse strings and are controlling the resources, who want evidence in a certain format and in a certain way, that prevention actually makes a difference? Combined with this, we're also facing the fact that we often are working around ill-fitting linear measures that are often not suited to capturing the power of prevention and the impact that prevention has. Often measurements, they like a process that has a nice linear role of this is the problem that's presented, this is the action that's undertaken, and this is how that action has then solved the problem. We know from talking to people working in this area, people's lives aren't linear, they're cyclical, they work up and down, we have flows, we have bounces of good periods and bad periods. So having that sort of way of trying to prove the outcome is not helping us in terms of creating that understanding. As a consequence of that, of both those budgetary pressures and those data pressures, prevention is always going to be an easy target for cuts when there's a pressure on, when there's pressures, because we can't evidence it in the same way we can evidence other things. So we need to be better at proving the value of prevention. Similarly, there seems to be, and I think the recent evidence is pointing to this, a lack of understanding around the importance of applying consistent work around prevention, not seeing it as something you can cut little bits off and salami slice every time you need to cut resources. Having 1 or 2 people active in that area, or having less people working across a bigger area, always is damaging the potential value of some of these preventative models. So it's important that some of these problems are addressed if we're going to get past this paradox. So this is what we've been trying to do over the recent years with some of the research, looking at how and where strengths-based prevention has been applied and supporting organisations to evidence the impact that they're having, trying to find ways in which we can really capture some of that work. We've focused specifically in our work on what we talked about, and would take Chu's lead of talking about second wave initiatives. So those initiatives that are moving on away from sort of demand management type approaches of reablement and the more simplistic sort of versions of prevention into these more fundamental revisioning of the connections between local services, citizens and communities. So things like the work around local area coordination, which is the report that you'll have been sent recently. We've also been working with a number of local authorities on studies around poverty prevention and alleviation, and looking at how the cost of living crisis has put pressure on some of those things and how they might rethink how we approach poverty prevention. And as a consequence of this, and you'll have seen in the 4-page that we sent out and the report, we think we've started to develop what we call a strength-based model that helps to explain how and why prevention works well, what it is we need to try and capture, and in the process started to develop some practitioner-oriented research tools that can really give an angle on how you capture some of this evidence. So Joe's going to give you a quick overview of some of the findings that we've pulled out and the implications for practice.
Yeah, okay. Thanks, everybody. Yeah, I think one of the most important findings really is the way that this is from the Local Area Coordination Project in particular, it's the positioning of local area coordination and its coordinators in what we've coined as the spaces in between the public service system, the local community and individuals, where this delivers benefits at all 3 levels. For example, for public services, it extends their reach into communities and to individuals, and also enables them to take on board and reflect on community insight that's generated through local area coordination. Also, for individuals and communities, it actually enables them to navigate the public service system much more effectively, which is really important in terms of getting the right support at the right time to people. It operates in a way that there's no fixed eligibility criteria, there's no strict time limits, which gives local area coordinators a freedom to build relationships with people, to work in a relational way across all services, all areas, services, communities and individuals. And as a result of this, it's been really successful at building the confidence, skills and capacity of individuals and community organisations to navigate and engage with the system, and also for individuals to engage much more in their local communities and become a resource to those communities. So what we've kind of come to the conclusion of, and the boundary spanners are not a new concept, it's an old concept, but it seems to be so appropriate to understanding the role that local area coordination and other strengths-based preventative models actually provide. They provide a connection vertically and horizontally across the 3 levels. They operate in the spaces in between where connections often get lost and where people can frequently fall through the system. They patch up and fill some of these gaps. Because there's a lack of eligibility criteria, they're able to work with anybody who wants to engage. And they stop people from being trapped in that revolving door around services, constantly having to retell their story and failing to get the support that they really need. So by being there, the concept of being there is really fundamental to local area coordination. They're there for the individuals, they're there for the community, but they're also there for their colleagues in public services and in the voluntary sector. They offer the support and connections to individuals that enable them to build insulators against the pressures that can actually trigger them back into crisis. they help them to build a suite of resources to navigate the challenges that they're going to face in their lives. You know, life is bumpy, isn't it? And what we are pretty certain of is that they enable people to bounce back more effectively so they can navigate these challenges much more successfully. We've talked about evidence, the challenges with evidence. We still haven't cracked it in policy and practice and in research around how you can effectively understand second wave prevention, strengths-based prevention, how it works, why it works for people, and what it delivers at all those levels. We used life story interviews in our local area coordination project and participant journey interviews in the poverty prevention work that we've been undertaking. And we find that it's absolutely fundamental because it gives you the context of the person. And we were able to build a strengths-based model through understanding how individuals, others, service providers and communities experience local area coordination. And that enabled us to build a strengths-based model that actually does get to the root of how it works, why it works, and what it actually produces in terms of benefits. We've got a whole series of tools. We would love to share them with you. We've built a cost consequence analysis framework with our health economics colleagues. We're going to test that through the next grant application. We have participant journey templates, case study data forms, and we've worked around developing effective process data. We would love to share these tools. We think it could be a game changer in terms of how we evidence effectively second wave preventative approaches. So just some brief policy recommendations then. It's absolutely fundamental to understand that the value that prevention provides if it's located as a bridge between individual community and public service systems. That these kind of preventative measures like local area coordination that operate in the places in between bring significant gains across all three levels, providing better connections and reach. So this is the advantages that this kind of preventative approach offers across the board. Prevention at the moment, I think, is seen as a kind of relatively safe area to make some cuts in. We would argue that actually investing in prevention is a strength and not a risk. It's not a safe place to cut, because actually what these preventative approaches do is they actually enable other services to connect much more effectively, to integrate support across services and sectors, bringing very much in the important role of the voluntary and community sector. And on that basis, they're more able to address what we're seeing increasingly, which is a rising complex needs of people presenting to the system, but also stopping people from getting to that point as well. What we need to really bottom is using the right tools for the job. We need bespoke tools. We need to understand the limitations that traditional linear measures actually offer us, and that we need tools that are much more effective at capturing the social care outcomes. And these are the kind of tools that we've developed through these our recent studies. To get there, we need to do several other things. So these are more kind of practitioner-based recommendations. So we think there's significant value in starting from where the individual is at. So understanding the individual's context and journey into the system. This enables us to understand the wider challenges they're facing and the complex needs that they're presenting with. We need to embed and connect support across the sectors and also within the sectors. There's not enough joined up working. The silos are still a really significant problem for us. And one of the things we mustn't do, and this came from a director of communities that we've been working with, is that we must not make the cuts in the areas that cost us the most in the long term, that lose us the most value from collaborative working. And the challenge is that in this current difficult climate of cuts, sometimes those cuts really strongly affect the ability for us to collaborate across sectors and services. And they're the very areas that we really shouldn't be cutting, because they're the areas where we can wrap around support, pool resources, and gain greater value from existing investments. We also need to understand better the impact and effectiveness of prevention beyond simply counting the basic numbers. And we also need to capture the individual's journey through the system so that we can ensure that the right support is provided at the right time and we avoid duplication. So there's just some key tips from the work that we've been doing. John, can you want to share the screen? Okay.
So that's the research in a nutshell. Very short and brief trip. As we say, there's the 4 pages that we've sent out, and there's the big report on the LAC study that involves a lot more detail of the strengths-based model and some of those recommendations. But we think that sets the scene quite well for the really interesting panel members to give their practitioner insights into what's going on in their location. Over to you, Harriet.
Thank you both. I can see there are some questions and comments popping up on the Jamboard, which is great, but can I ask, maybe I probably wasn't very clear about this, if we can use the chat function for kind of technical questions, and yes, we will be sharing the slides afterwards in response to those few questions. The Q&A for the kind of discussion, and then the Jamboard is for kind of what you want to get out of the network moving forward from today. It's a bit confusing with the 3 different ways. And very fair question from Martin, can presenters introduce themselves? I forgot to introduce myself. I'm Harriet. I'm a lecturer in organisational behaviour at the University of Hull. John and Joe.
I'm Professor Joe Cook. I'm at the University of Hull in the business school, but essentially I'm a social policy academic.
And I'm John Birchall, and I work at the Management School at the University of Sheffield, and I'm the co-participant in all these different research projects.
Thank you. Sorry about that. I got biographies for our speakers so I could introduce them, but I forgot about myself and my team. So it's time to get into our panel discussion then. So first up are York City Council, who are long-time friends and collaborators of ours. We've been working together for many years. So we're very lucky to have Joe McKaylee, who has had a 30-year career in community development and citizen engagement, spanning both voluntary sector and public sector. And Joe is currently the head of communities at the City of York Council, and he leads the communities and prevention service, which includes local area coordination and the local authorities' approach to becoming a more relational council. And Joe is joined by Jenny, who has been a senior local area coordinator since 2019. Preceding this, she had a varied career in mental health, social care and homelessness, following an academic background in social sciences and humanities. So I'm going to hand over to Joe and Jenny to tell us all about what they've been up to in York.
Can you see my screen all right? Has that worked?
Yeah, thanks, Jen. It's worked. So, morning, everybody. I understand there's lots and lots of people on the call, so really good to be with you this morning. It's a double act from York, with starting with myself and then Jenny talking in more depth about our local area coordination approach. So I was asked to say a little bit about York's prevention strategy. So York, and in particular adult social care, reflecting rising demand for public services and often intervening at a point of crisis in people's lives, introduced a community operating model in 2016 that focused more deliberately on early intervention, prevention and asset-based community development. And as a result of that, we have deliberately invested in a number of evidence-based approaches, including local area coordination and other asset and strength-based approaches that we know should support people to lead good lives and stay out of the services within the system. Because we're very much strong believers in the vision of social care futures that is also on the slide, recognizing that we all want to lead a good life, be happy, healthy, connected, safe and in control and at home, as opposed to being in service land. So we have invested in a number of approaches, as I've said. We very much believe in supporting the teams and initiatives to connect and collaborate and work across the system, and recognise the power of good relationships. we all recognise that when people have good relationships in their lives, things are better. Our local area coordinators are fantastic relational centred practitioners. So we see relationships very much as being an end in themselves as opposed to a means to an end. As a result of this collaborative approach, we are trying to create the conditions for people to thrive and have good lives and build on their own gifts, their skills, their talents, their agencies and capabilities to achieve good health and wellbeing outcomes that reflects our wider vision for York to be a health generating city. Next slide, please, Jen. So I've got the Think Local, Act Personal rainbow of community-centred approaches up there, reflecting that investment in strength and asset-based approaches that we've tried to do. We very much largely have the rainbow in York. We have local area coordination. We have a fantastic social prescribing programme. We have home share. We have a version of the Cares family model of social clubs, a health champions program, good gym, I could go on. So a part of our prevention strategy has been deliberately investing in these approaches, recognising the evidence base, but supporting the teams and initiatives to connect. Next slide, please, Jen. So local area coordination, John and Joe have spoken about. I can honestly say across my very long 30-year career, it's been the best thing I have possibly been involved in terms of the outcomes it achieves for individuals, supporting people to be not passive recipients of services, but recognised as active citizens. It supports the development of more inclusive, connected communities, and hopefully a system that is more human, recognising how we are trying to rehumanise value. So local area coordination, again, John and Joe spoke a bit about, has been around for a long time, over 30 years now, originating in Western Australia. We are part of a national network, the Local Area Coordination UK network, and I always refer to us being a part of a family as recognising our membership at that network. So local area coordination fundamentally helps communities to become more inclusive, welcoming and self-supporting places. It supports people to stay strong and prevents the need for service intervention by building on personal strengths and finding natural support through local relationships. It supports people facing crisis to get a person-centred service within the context of a supporting community network around them. It helps public services to transform so they are integrated, person-centred and co-produced with communities, and it reduces costs to the system as a result of people requiring less assessment, intervention and expensive ongoing care. We feel that we have inverted a narrow focus on finance and scarcity of resource in York to one of abundance, reflecting the power of people and the relationships and connections between them. Next slide, please, Jen. We were asked to talk a little bit about challenges to preventative models, again, as John and Joe have said, and there are many in the current financial climate of diminishing resources for local authorities, increasing demand on public services and people struggling, not least that being exacerbated by the cost of living crisis. So it is becoming ever more important for us to evidence the impact of early intervention and prevention and asset-based approaches. And this is something that we have spent a lot of time on with the local area coordination team over the last year or so, reflecting the development of a cost consequence framework. Furthermore, that's exacerbated by further challenges to the voluntary and community sector. I know NCVO have done some research recently and they've identified that possibly 1 in 5 VCSE organisations face a funding cliff edge before the end of the year. So our point of working in partnership with people and the voluntary and community sector to recognise the need for active and resilient communities to support prevention is also a threat and be a challenge at the moment. But I think one of the solutions for us is to recognise that we all need to be in this together. We all need to collaborate. We all need to look through more of a human learning systems approach recognising the power of people, the power of community, and recognising lived experience. Local people know best. They know their lives, they know the outcomes they want to achieve. And it's very much about recognising that there's no one sector that's going to deliver a solution to this. We need to collaborate and work together to work through this time of crisis and challenge. But not least, evidence more effectively the value of early intervention and prevention, and try to shift the dial to the left to get more investment in this. And hopefully with an incoming new government, we're going to see that reflecting the community power agenda and their desire to focus more on prevention and resilience and a reimagined social care model. Next slide, Jen, and it's over to you.
Thank you. Thanks for that. So in response to some of these challenges to preventative models that we've heard Joe and John talk about, too many Joes on the call, we've been working hard in York, reviewing and reimagining our monitoring and evaluation framework for local area coordination. So there's been quite a lot of pressure in terms of budgets and finances within the local authority, and specific requests from senior leadership for us to improve the kind of metrics that we have in terms of our monitoring and evaluation. So in local area coordination, in the programme in York, we've always used a mixture of qualitative and quantitative measures. So we capture stories, case studies, along with a suite of metrics. A lot of the metrics that we had focused on reasons why people were introduced to us, the reasons why local area coordinators were walking alongside people, and some of the outcomes. We were asked to provide more metrics around our value, any cost savings to the system, and evidence these. So this slide shows the results of a methodology that we've developed, and we sort of tested this out with a deep dive for 2023. So this wheel shows that we estimate that we saved approximately £6.8 million over this year by preventing, avoiding or delaying key statutory system interventions. We looked at the cost savings to the system across the whole LAC team, which is 13 out of 21 wards in the city. And this was a sample of 1,159 cases, or people that we'd walked alongside. We used system intervention costings from the GMCA spreadsheet, so that's the Greater Manchester Combined Authority. They gather national averages of cost of system interventions. We added a York premium to these costings, reflecting that the cost of living in York is slightly higher than the national average. And where possible, we used local data. So for example, the average cost of an adult social care package of care and support is £35,000 a year. And we got that from our business intelligence team. We chose 14 areas across 7 sectors of the system, and that reflects that the LAC model is a really broad expert generalist model. So we work really broadly across the whole system, from the voluntary and community sector to the service system. It was really difficult to pick which areas to measure. So we've tried to just pick a broad range that you can see kind of broken down on this slide. The vast majority of these savings you can see sit with adult social care. So out of that 6.8 million, nearly 5 million sits with adult social care, followed by children's social care. And across these broad areas listed on the right-hand side of the slide, we broke them down further into subcategories. So for example, in adult social care, there's 3 subcategories. This work is very much under development, and we're always at pains to sort of say it's not an exact science, it's not perfect. We're very much working on this, and we're working with John and Joe's colleagues, the health economists, who have been working on the cost consequences framework that they referenced earlier. Alongside these cost savings to the system, we've measured 3 themes that we couldn't attach costings to. So you can see those broken down on this slide. Hospital discharge, supporting a family to stay together or regain contact, and reducing loneliness and isolation, which is a key part of the LAC model. The other 2 measures on here, they were specific requests from senior leadership that they wanted to see the impact in these areas. Again, this was a sample of 1,159 cases across 2023. And you can see that the numbers of impact are quite high. There was 406 successful outcomes against these 3 themes. Alongside the metrics that I've outlined, we've been developing what we call the York Good Life Survey. This is to look at some of the kind of softer outcomes around wellbeing, improving confidence, all of those things that we know are equally as important. This graph shows the responses from quite a small sample of about 40 people who've completed the survey. But you can see already the blue line represents where people were before LAC intervention and where they reported themselves to be across these outcomes after walking alongside a local area coordinator. So, for example, with loneliness and isolation, there's a percentage change from 15 to 46, which is a 200% improvement rate. We developed this survey from the Adult Social Care standardised survey. And again, this is under development. We know that we need to do more work on this and liaising with academics around this. So finally, we were asked to talk about some of the challenges to evidence in prevention. This has been, it's been a really difficult year trying to review our monitoring and evaluation framework, develop these methodologies. And some of the key reflections on that hard work is we're measuring what hasn't happened often with prevention. So there's an element of guesswork in there, which we have tried to mitigate with a comprehensive guidance document around the cost savings to the system. So we have a guidance document. We did from qualifying actions taken from hundreds of case studies and stories that local area coordinators had captured about people that they'd been walking alongside. But we're very humble that it's still not an exact science. There are infinite variables. So when we were looking at this, it was so difficult to work out what we should measure, as I mentioned before. But also, we're not sure what else may have made a difference. It may not have been the intervention of the local area coordinator. There may have been 100 other factors. We're really mindful that when we're measuring these cost savings or potential cost savings, there could be costs that are deferred or displaced elsewhere. And again, we're working with the health economists, John and Joe's colleagues, to try and factor in some of those things that might offset the data that we're capturing. In a lot of ways, we're trying to measure the immeasurable, especially with some of those softer outcomes, increases in confidence and well-being, changes to people's lives, especially when we work in such a person-centred way. These things are really, really difficult to quantify. And community cohesion as well, things like that are so difficult to define in terms of what it feels like to live in an area and how that's improving. And finally, impact on practice has been something we've had in really sharp focus when we've been developing this work in this framework. The more time we spend recording data, the less time we have to walk alongside people and actually make a difference, to make those differences that we want to measure, to achieve those outcomes that we want to measure. So throughout this whole process, we have been really mindful of that and trying to make the recording systems that we develop as, you know, as simple as possible, so it's not onerous on the local area coordinators, and they're able to do the relational work that they're really good at doing.
Thanks so much, Jenny. I'm going to have to.
I'm done. I'm done. I was going to say, and at that, I think I'm just about hit time.
That's great. Thank you so much. What a journey you've been on at your council. So there's a couple of just quick clarifying questions that I just thought I'd put to you before we move on to our next speakers. So Charlotte was wondering whether the cost savings model and the numbers that you presented are just for local area coordination, or is that for all prevention measures in the council?
So the slides that I've just shared, that's just for the local area coordination team.
Okay, fab. And there was another question from Jane about what did the number on the left of the last slide represent, but I'm not totally sure which slide you're talking about, Jane. So if you could drop that into the questions, then maybe Jenny can answer that. And there was another question as well about from Jane about whether LAC officers take a proactive approach, for example, checking up on people living alone with dementia who don't have family and friends nearby.
Very much so. We're very flexible in terms of how we work with people, and we devise what we call a shared agreement around a good life plan. So it's whatever a good life looks like for that person. If that means sort of regular check-ins to make sure that people are okay. We often provide a bit of a safety net for people in that way in communities. So people with long-term fluctuating health conditions. We don't have open and closed cases. So in that way, we can be really visible, really accessible, and we do a lot of that kind of popping in just to see if people are okay.
Fab, thanks, Jenny. Okay, well, there's plenty of questions coming in for the discussion later, so that's really exciting. Lots of really good questions. Thank you. Keep dropping them in the Q&A bar, and Ben will keep organising. So next, we're going to hear from Oldham Borough Council. Oh, my screen's just gone wobbly on me. There we are, who we began working with during the MOVE project during COVID. So we're thrilled to introduce Amanda. Why does my screen? Hi, thanks, Amanda, who's a policy manager within the corporate strategy team and performance director at Oldham Council. She's got more than 30 years of experience in local, regional and national government policy making and programme management in relation to urban regeneration, housing, sustainable development and planning. And Amanda is joined by Rachel Dyson, who is the Thriving Communities lead at Oldham Council, who has 15 years of experience in local government, working across communities, adult social care, policy, and now public health. And she's also worked for the Greater Manchester Combined Authority as well on the public service reform agenda. So over to you guys.
Hi, good afternoon, everybody. Good afternoon. We're even in morning, aren't we? Good morning. I'm going to start us off. It's a bit of a double act today between myself and Rachel. I'm Amanda. Going to firstly just set the context a bit for people who aren't familiar with Oldham and some of the challenges we do already face. We're then going to look in particular at the prevention challenge that we've got, the development of our performance management framework, our prevention framework, look at an example of how we're trying to work towards prevention whilst dealing with crisis, looking at our cost of living response, and then finally just look at how we're looking to move forward on this work using the learning from the evaluation that we've been engaged in with Hull and Sheffield University colleagues to help inform that. Oldham is there in front of you. We are a town just north of Manchester, old industrial mill town, sitting on the edge of the South Pennines and the Peak District. Next slide, please, Rachel. few facts and figures for you. We have a population of around 240,000. That is growing, and we have a young population in Oldham. Next slide, please, Rachel. We're ethnically diverse in the borough, so we have roughly just under a fifth of the population from our South Asian community, which is relatively a settled and long-standing community, predominantly Pakistani, Bangladeshi heritage. But we also have people coming to us from all over the world now in terms of emerging communities, people seeking asylum, refugees, and making up more and more of our communities. The borough is almost a borough of two places. We have significant health and wealth inequalities in the town. Our affluent areas are situated more to the rural areas to the east, around an inner core where we have significant challenges around social and economic deprivation and disadvantage. Some of the figures speak for themselves there on the slides. Our child poverty rates are going in the wrong direction and have been for some time. In terms of things like free school meals, we are seeing an increase in that, and particularly in those areas where the rates are already high. The map you see there, you could basically apply to poverty, income, unemployment. Generally, the pattern would be the same, with the greater disadvantage, the least affluent areas concentrated to the centre and west. Thanks, Rachel. So this has been alluded to. We find ourselves in a perfect storm, like many other local authorities. We have increasing inequalities, increasing demand for our services, particularly crisis services, in a time of reducing resources. The impact of austerity, I think, is well documented. Certainly in Oldham, we have really struggled with declining budgets over the last few years. As of last year, we'd probably lost around £217 million from our budgets over the time, exacerbated by COVID-19 and cost of living crisis. So what we've seen is where we have disadvantage and poverty, that has increased in those areas as a result of those two events and is still ongoing. Colleagues in York have referred to the ongoing financial challenges facing local authorities generally. Again, we are no different to that. We are under extreme pressure at Oldham in terms of our budgets and the savings we still need to make. Our demand for crisis support remains high. It hasn't gone down yet. So the cost of living crisis is still with us. And in Oldham, we have a particularly complex political environment. We've had 4 leaders since 2018. And at the last election have just moved into no overall control from the Labour group administration. So things are always very fluid in Oldham, and again, trying to think long term in that context, it can be even more challenging, to be honest. Next slide, Rachel. So just to say demand is still high, we've taken the example of our food bank deliveries. As you can see, it's been up and down. We're starting to go up again, which is a real concern. Similarly, Citizens Advice are dealing with probably 3 times the number of calls that they were 2 years ago, as is Access Oldham, which is our helpline and customer service, mainly around low income, help with housing, benefits advice, that kind of work. Thanks, Rachel. So to me, this sums up the prevention challenge, and this was taken from one of our focus group participants in the evaluation that Hull and Sheffield have done. it says it quite plainly, so I don't think there's any need to reiterate that. Moving on, Rachel, please. So I'm going to hand over to Rachel now. So this is about our performance framework and what we've done to develop that.
Thanks, Amanda. So I'm just going to talk a little bit about work that we've done over the last 18 months or so in Oldham to develop a kind of system-wide prevention framework is how we're describing it. So the drivers for starting that piece of work really came from a number of other pieces of work, in particular an analysis of adult social care demand by some external consultants, and an evaluation that we've done of our social prescribing model and our sort of model for investment in the voluntary community sector. And both of those pieces of work really pointed to the fact that we needed some form of system-wide approach to prevention. So it was there in all our individual service strategies, but actually we weren't necessarily talking about the same thing, addressing the problem collectively, and understanding what we were aiming to achieve collectively. So the piece of work we did was trying to address some of that, and really to build a framework that helped us to understand what we wanted to achieve, what outcomes were we intending to achieve, you know, what did we mean by prevention, to help us talk in the same language as a system, and to sort of begin to address issues around commissioning, duplication of resources, gaps, to look at where we've got some shared enablers around things like workforce, data sharing and so on, to support that work. And we worked with people from across the council, from all different services, as well as voluntary sector colleagues and colleagues from our integrated care partnership. So as you can see, we've kind of got a very simple framework, nothing new in the kind of triangle of need, and then sitting beneath that, we've developed some definitions really of what we mean when we're talking about prevention, to try and start that process of talking in the same language. And actually what we found when we did this was that we were often talking about what was going on for the resident, or we might be talking about what we offer and defining it in those terms, or we might have been describing the intervention. So through this kind of matrix that I've put on screen, we're trying to show all those different things alongside each other. And the framework really recognises that people might be anywhere on this framework at a particular time. They might be in more than one place, and services might be working across the different levels. But it's an attempt to try and describe what our prevention offer could and should look like. And it also recognises that prevention can happen at any point, from when you're kind of living well and everything's going well in life, up into those people that are experiencing problems and challenges or crises. Prevention can happen at any point in the system. So we then sort of went on to look at some principles underpinning the framework, and I think these are really quite similar to what John presented earlier. So we've got some principles about how the framework operates. It should be strengths-based, should be built around people, not services. We should be working to purpose and outcome, not time-driven or target-driven. We should be building a shared understanding of the support that's available. But we also identified through those conversations some investment principles. So looking at how we can commission less, design more, work with our communities to do that, and focus our investment around prevention and demand reduction, while seeking to remove barriers to effective delivery. And we've also got principles around how we work with residents. So it's about enabling people to help themselves. It's about helping residents to know how to access support. It's trauma informed, it's whole family, it's coordinated, it's not about repeated assessments and handoffs in the system. And through that work, we also then, once we developed the framework, looked at mapping what's our current prevention offer against this, how does it compare? And what we found was there was a significant complexity in our offer. Although we've got a really good number of services actually supporting a preventative approach and achieving a positive outcome with residents, but it's quite challenging to make sense of that as a whole. And some issues arising out of that complexity are, we know we've got more services and investment at the complex end, even when the intention is prevention, and we've got less investment at the staying well, living well levels, which means people and services are often pulled into more complex work, and root causes of people's issues remain unaddressed. Commissioning can be siloed, so we might be filling gaps or reducing capacity, but not actually understanding the impact of that on other service pathways or contributions to shared outcomes. We have a workforce who's doing an excellent job, but very much in the thick of crisis, providing support, dealing with problems, not with the space to enable people to address issues themselves or look to reduce the need for support. And we're not always taking that whole person, whole family approach. The landscape of services can be difficult to navigate. We've got a lot of front doors, gateways, and that operational integration is not effective all of the time, and our IT systems are not joined up. And with all of that comes some failure demand within the system. So that complexity produces barriers to access, and the transitions between services often mean people fall through the net. So just before I pass back to Amanda, we're going to kind of talk a bit more now about some of our kind of prevention and action, how we've looked at addressing the cost of living crisis, and how we've tried to build in a preventative approach and to understand the impacts, with support from colleagues from the universities of Hull and Sheffield. But it's not a sort of recent journey. You know, we've been on this journey for some time in terms of particularly working with our voluntary sector partners around addressing poverty. Our pandemic response, working very much in partnership, has informed the approaches we've then taken. We had a Poverty Truth Commission began in 2021, which has then led into and fed into our approach to tackling cost of living and our current work around Poverty Action Network. Pass back to you, Amanda.
Yeah, so just basically to now look at an example of the cost of living crisis and how we're working towards prevention at a really challenging time. So, as I've said, you know, the cost of living crisis is compounded existing disadvantage in Oldham in a nutshell, and increased the demand for our services, which was high anyway. Organisationally and across the partnership, we've probably been operated in crisis response mode. In response to that, very much focused on operational activity to help address people's immediate needs. But having said that, we have been working differently, using a strengths-based approach and tackling the underlying issues where we can. So, for example, as part of our response, we work with Action Together and our Poverty Action Network members to deliver strengths-based training to staff and partners around how to have difficult conversations with people to get to the underlying issues, and then spend the time trying to make sure that people were then correctly signposted to access that advice that would help them in the future, as well as deal with the immediate need. We developed tools like the Money Advice Referral Tool, which is still in use now, and which we've actually developed more bespoke models of, which basically give people one-stop shop access to help and advice, particularly around finances, so to hopefully enable them to better manage. We've also mapped our front doors against the prevention framework. Next slide, please, Rachel.
Just got 1 minute left, Mum.
Yeah, no problem. So basically this was trying to map those tracks through where people were presenting and how we could then think about enabling an earlier intervention, even if people were at the point of crisis. Rachel, do you just want to move quickly through the others? We learnt from the evaluation by Hull and Sheffield around the key presenting issues, which has since helped us to try and think about where we focus our resources and how we in particular look at how we provide financial support and advice. The fact that one half of respondents has had prior contact with us shows us that our prevention approach wasn't working so well. So we've had lots of useful learning from this, including the role of the voluntary sector and that relationship building. Next slide, please, Rachel. really support and assistance. Please, Rach. Barriers speak for themselves. We can quickly pass over that. Enablers, we've just spent the last 2 sessions talking about this. Person-centered working, cross-service working, individual support networks, trusted relationships, absolutely key. Thanks, Rachel. Impact, just bear with us a second on this, Harriet. We were successful. We were successful in helping people in crisis. And importantly, that bought us time. And it bought those people time to keep afloat, to try and then address some of the underlying issues, which is then what we did through our changed approach. And it was seen as effective. People did report an increase in income, but we don't know the longer term impacts because it's a short term programme. And then just finally, medium term, we do know that 1/3 of respondents who received support then volunteered to help others. That's massive for us in terms of that learning around prevention. And finally, Rachel, last slide. This is all the work we're currently doing, which we could go on that greater length about in terms of taking the prevention agenda forward, following on from that learning. So thanks for that. Whistle stop.
Thanks, Amanda and Rachel. Amazing stuff going on in Oldham, in spite of all the challenges. So that's great. Kerry's joined us, so we'll move on to hear from Bradford, and then we'll do the questions after. So lastly, but certainly not least, I'm pleased to introduce Kerry Lee Barr, who is the Development Director for the VCS Alliance, VCSE health infrastructure organisation across Bradford District and Craven, working in partnership to influence and transform health and social care.
Hi everyone, great to be here. I'm not going to speak about Bradford District and Craven's entire prevention agenda, but what I am going to do is give you a real example of one initiative that is now being addressed as an integral part of our infrastructure in support of our prevention strategy. So our wellbeing network was created about 18 months ago. And to set a bit of context around Bradford District and Craven, we have particularly stark health and social inequalities for people living right across Bradford District and Craven. And as a really socially and culturally diverse place, we have some very specific needs across our communities, and our wellbeing hubs offer a solution to those who traditionally struggle to access NHS services, and for those with much poorer outcomes. Next slide, please. So our hubs really and our network was came out of the ICB's recognition of the incredible work that the voluntary community and social enterprise sector did in response to COVID, and how we were able to flex and adapt and be agile around our response to people in communities. And so we had discussions in our urgent care delivery board about how we could use winter pressures monies to kind of devolve that into the VCSE, and how we might use that in a different way to support increased pressures and demands. And the aims around that were to coordinate early help and prevention, and specifically looking at waiting list management and activity and involvement of community staff already working in neighbourhoods, and how that linked into statutory services and vice versa. And there was a real focus on enablement, specifically about positive risk taking and how we can really work together under our Act as One framework to build the support and offer for people in communities. And to accelerate our Act as One plans. So looking at our community mental health transformation work, our localities working, our multi-agency support teams and multidisciplinary teams right across our place, and how we could bring those together to really work in a very focused and collaborative way. And we were testing some concepts there about how we could enhance the existing VCSE provision right across our district, how we could add new VCS provisions specifically around out-of-hours services, and some of the challenges that we face, some of our people face about accessing services out of hours, and also how we could reduce increased pressures right across the system, so not just in secondary care and acute, but also in primary care and some of those wider services. Next slide, please. And so our network began 18 months ago and was born from a culmination of our system data that gave us 6 hotspots, if you like, across our district. And so what we were given 1.7 million to co-design a solution to those challenges and concepts that needed attention. And our sector designed our wellbeing network in response to that. So we have 6 wellbeing hubs located right across the district, all coordinated by local trusted organisations from that community. And wrapped around that, we have 8 what we call out-of-hours services that are supporting either gaps in geography or thematic need right across the district. Next slide, please. And this really is what the model looks like in practice. So each of those hubs has a range of services, existing commissioned services, already delivered by VCSE organisations, delivering from those hubs. So support in refugee and asylum seeker support, domestic abuse, carer support, welfare benefits advice, and substance misuse. And there is a consistent approach to the delivery across all of those sites with these services. In addition to that, each of those hub sites has a mental wellbeing and a physical health budget that gives them the ability to procure locally based on their local priorities and need. And the benefit of this particular network have a consistent approach right across the district, but with the ability to act at a hyper-local level. Next slide, please. So what brings people to the hubs in the first place? So the first thing that we've identified is that people often are in an absolute sense of overwhelm and are self-reporting that they are in crisis. This real sense that life is absolutely just too much to manage alone. That they've had specific problems around accessing services. Either they didn't know where to go to access the support that they need, or they don't know what's actually available. And we've an increasing number of people who are accessing the service who feel like they've exhausted all other options, or a door has been closed. They've completed their 6 sessions of IAPT, for example, and they don't know where else to go, and they still require some support. The complexity of the need that we are working alongside is pretty stark, and often people will present with a single issue, but when we take people through a really in-depth triage process, we have the ability to identify the multiple and complex challenges that people are facing around their wider determinants of health. And often it is not just the individual that needs support, we're also supporting that family network or their circle of support. An increasing number of people with complex mental health issues, and people are self-reporting being anxious or being depressed. And of course, as many people have already alluded to, you know, the social economic factors that people are facing, the reality is that we're seeing people saying, I don't know whether to feed my family or to pay my bills. So that increasing financial pressure and burden upon families is having a significant knock-on effect in terms of the family's emotional well-being and the kind of resilience and eco-structure that they may have had once before. Next slide, please. So I thought it'd be useful to just share a little bit about what some of the presenting issue data is showing us. As I said before, people don't know literally whether to pay their bills or to feed their family, and so may not be a surprise that the majority of people that are stepping over the threshold of our wellbeing network is to ask for support around welfare benefits. And of the 22,000 interventions that we've already delivered, which don't include group work or trust building conversations, we know that we refer people into that wider service that I described in the original model, another 5 referrals into that network. So the complexity that people are facing is stark. Next slide, please. In terms of reducing pressure to the overall system, we asked people where they would have gone had they not have access support from their wellbeing network hub, and over half of people have said that they would have gone to their GP. They didn't know where else to go. And I think it's really interesting that only 13% of people said that they would have asked for support for a friend or family, and that really acknowledges for me that wider challenge that we have around loneliness and isolation that people are facing, and actually a lot of shame and stigma around that presenting issue that I've just described that people are facing. And we're able to track, you know, using our postcode data, where people are they living in the most, the areas of multiple deprivation, and are areas of inequity right across the system. So we're using that data to constantly build and navigate and redesign the service itself. Next slide, please. So, you know, we have huge success and opportunity, and with that comes stark challenge also. Many of the presenters have already recognised the challenges that we are all facing, and particularly as a Bradford district and locality infrastructure. The network itself has been awarded £1 million recurrent funding, which on the face of it is an absolutely huge win for the voluntary and community sector. And that's a £700,000 shortfall in our operating costs. And so we are having to go back and redesign what this service looks like and how we can embed that into the wider system to develop a model that is fit for purpose and is still serving people who need it most, essentially. We have now over 30 BCSE organisations working in true partnership right across our patch. And one of the real benefits of this is the sharing expertise and knowledge and the organisational peer support that has evolved as a result of working in this really collaborative way. Our evaluation acknowledged that from people in our communities that the biggest asset of the network itself was really captured in 4 words: access, trust, connection and hope. And I think those are the values that we hold on to as we're developing and we're operating the new iterations of the service as we move forward. And of course, all of those are tested in times of extreme financial challenge right across our system. I think that's a huge opportunity to create additional provision and skills in response to changing community challenge. You know, it's not a one size fits all. Things are changing in our place and within communities, and how do we keep abreast of what is happening in communities. And so our network of VCSE organisations can bring that insight and intelligence back into the system, so to help us to shape and create services in response. We're looking at lots of co-location opportunities. We're looking at mutual partnerships, about where can we really get the best value out of shared referral pathways, for example, and readdressing our impact. So working with the LAC evaluating team on how we develop a specific impact tool, because as it was mentioned before, there's always this driver about the journey or the progress that somebody's making, without necessarily acknowledging that for some people just standing still or being in one place is just as important, and they may actually be able to deal with the next challenge that life will bring in a more impactful way, and in a way that is in support of their own emotional well-being, and to keep revisiting our data and acknowledging our gaps, whether that be geographically or thematically, right across our district, still remains a challenge. Next slide, please. Evidencing impact, I mean, it's been really interesting to hear what others have said, but I think the challenge, or the biggest challenge for us, has been having the ability to recognise and demonstrate the added value of this service, and in particular around, you know, having metrics that are fit for purpose. And so we are working as a partnership to design a set of metrics, not just for the wellbeing network, but for the VCSE sector as a whole. How do we understand and recognise the true value of services being delivered in this way in that early intervention prevention space? Closing the gap, you know, and that's not specifically just considering how we navigate our financial gaps as we move forward into you know, significant deficit budgets, but also about, whilst we're doing that, are we making sure that we're not amplifying the gap of inequity right across our district too, and we need to understand that and be able to evidence in a different way to enable us to do more of this work right across the district. And I think another thing that is incredibly challenging for us is the ability for us to flex and change services to meet needs, and how we evidence that, and in support of how we redefine programmes at a strategic level. I think, am I at time?
You are, yes. Thank you so much, Kerry. Yeah.
No worries.
Thank you for sharing that. It's really interesting stuff happening in Bradford. We're always pleased to share where the voluntary and community sector are leading on this stuff. It's so important to amplify the voluntary and community sector's voice and role. And somebody had commented on the Jam board about the network, and is it going to be for local authorities or for wider system partners? Absolutely, for wider system partners, we want the voluntary sector to be really involved, and we're pleased to have representation from you here today. My blooming screen keeps jumping around, so just bear with me. There's loads of questions coming in, so we'll move straight on to the Q&A. Please share your experiences as well as your questions, and some comments have been coming in as well, kind of expressing thanks and congratulations on excellent work, as well as solidarity, you know, in the face of the big challenges. Jane had commented on Oldham's context, said about it being a kind of moving and sobering comparison with the situation in York, and that the statistic about 30% volunteering is really amazing, and a success, kind of utilising the strengths of communities living in poverty. So I wanted to share that. So I thought maybe if we'll start with, there's a specific question here for Kerry about, oh, where has it gone? About the dominant result that came up was other and was there further information about what that might be?
Is that around presenting issue or sorry? Yeah, and so that is where there are a multitude of answers within that, and it's where it hasn't necessarily fitted into the data that we needed to collect. And so, you know, one of the challenges that we have is around remunerating VCSE organisations to capture and do the administration to enable us to prove our worth, for want of a better term. And so often some of those key areas and that rich insight and data is collated as other. So we are working on how we can improve that moving forward. But yeah, it could be a whole host of things.
Fab, thanks, Kerry. And then there was another particular question, which was if people come to the hub with significant mental health issues, but they've already exhausted other things like IAPT, or have struggled to engage or not been eligible for certain services, how is the Wellbeing Hub able to support them in that case? That's a question from Naomi.
I think the absolute benefit of the Wellbeing Network absolutely is using that LAC model. So how do we support people with themselves? How do we support them with their wider community? But that we can contain people and support people to navigate a wider system. So we're doing the legwork on behalf of that person. So we're already, you know, we sit across all of our priority streams right across our ICB. And so we know where it is that we need to go, and we've got a really robust steering group full of leaders from right across the local authority and health that support us to navigate some of the more complex challenges, and we kind of have a case management MDT frequently to help us address the operational issues, but also that layer above around often there are themes around barriers, and we need people from our systems who can help us remove some of those barriers, but also that we're as a collective working through those real challenges that people are facing.
Fab, thanks for clarifying that one. There's also a question, what's the name of the other speaker on John Birchall's screen, please, from Nell? That is Professor Joe Cook from the University of Hull. So there is a couple of particular questions for Oldham as well. One being, is Oldham still the home of the tubular bandage? From Martin. And then could Rachel please say more about what she means by commission less, develop more, and perhaps give some examples?
I think we are still the home of the tubular bandage. We certainly, our voluntary sector has certainly benefited from some of the philanthropy associated with the development of that. So yeah, it has a legacy. Is that right, Amanda?
Yes, but we don't have the rail bridge anymore, sadly, that used to have it emblazoned across the top of the railway bridge.
So I think in terms of commissioning less, designing more, I think it was. So that's really about more co-production in the way that we design services. So focusing less on a very sort of straight procurement approach and using different methods to develop services. So one example of how we've done that in Oldham is our social prescribing model we did as an innovation partnership model, where we kind of went out to the sector and said, we want to develop this, who wants to work with us on it? And the contract was a developmental contract, and that's kind of worked over the last 5 years to design the model as we went, rather than going out with, we want you to deliver this, and we've defined it in these really precise ways. So it's sort of trying to be a bit more flexible, particularly when we're talking about people-based services, in terms of how we design and develop them.
Fab, thanks so much, Rachel. That's great. I don't know if the other speakers wanted to come in and had anything to add on that kind of commissioning, developing idea. Yes, Amanda.
It's not necessarily commissioning as such yet, but certainly in terms of listening to people with lived experience, we're currently doing some work to beginning to look at redesigning our children's services around the edge of care side of the service. And what we're doing is looking at how we engage care experienced children and young people in that discussion about the care service, but we're also pulling in part of our adults service that deals with women in particular who have very complex needs, have been known to services for years, may have had children removed, so that what we get as good a picture and as good an understanding as we can of what works and generally what doesn't work when we're looking at that move to earlier intervention and prevention based upon what those people with lived experience are actually telling us. So yeah, we are beginning to embed this approach very much across our services now to become more responsive and to be able to intervene earlier.
Thank you, Amanda. There's a few kind of specific local area coordination questions that have come in, so I'll put those to Jo and Jenny, although I would point you in the direction of our 4-pager and our report, which has been shared with you for more information about local area coordination. But what makes a good local area coordinator? Where are they recruited from, and what training is given to them? What do they do? Are they community builders? How many are there? How many life plans or cases do they have? A few questions coming in. I don't know if Jenny or Jo, you want to give a kind of quick overview, a bit more information about local area coordination.
Yeah, I can do it. Really good set of questions that was. I mean, fundamentally, our team of 12 local area coordinators are recruited based on their values. You know, they need to be peoples, you know, they're person-centered, and there's a variety of backgrounds in terms of mental health, adults and children, social care, the voluntary and community sector, but they need to be people. And the values that they're recruited on very much reflect the values of the local area coordination model, which is a high fidelity model around citizenship and inclusion and connection and relationships and supporting people to be in control. There were numerous other parts to that question, Harriet. What else was there?
How many cases do they have, and are they community builders?
So the team worked to hold in a caseload, if it's meant to be full, of between 50 to 65 people that they would be walking alongside at any one time. Generally at the moment in York, we are over that caseload number, reflecting the demand. The role is split into 60% of walking alongside, 20% is about community building, very much reflecting that the people that we meet, supporting them to connect, to grow new initiatives, and the other 20% is about the writing up of stories, administration, the metrics, and as Jenny was saying before, we've been doing more of that, reflecting the need to evidence demand in the system and cost avoidance and prevention.
Thank you.
Can I come in and just add a little bit just from the the research as a whole, because we work with 4 different local area coordination sites in total over almost 3 years. And one of the unique things, and I'm sure this is also similar for Kerry and the VCS workers in the wellbeing hubs, is that what people found who work in these roles is that they were finally allowed to work in the relational way that they'd always wanted to, but their other roles, the previous jobs, never really allowed them to do that. And so the brilliant bonus at a time when we're really struggling to recruit people to work in public and voluntary sector services is that because this gives them a level of freedom, those types of preventative initiatives don't have any trouble recruiting and they don't have any trouble retaining their staff, which shows the quality of the experience that the staff have, as well as the people who receive the support through that system. That's it. That's all I have to say.
Yeah, the local area coordinators we work with, they all just absolutely love their jobs. It was so nice to see. Okay, so let's kind of zoom out then, and I quite like this question that's coming from Martin. It's a bit of a broader question around prevention as a concept, and this is something we've been grappling with as a research team recently. So there's, you know, quite a debate going on around the word prevention, and especially when it links to managing demand. So Martin is saying this can lead to unhelpful dynamics when trying to explore what a win-win of good lives, where people avoid things they don't want, like institutional care, via things they do want, like connections, relationships, and purpose, rather than things just done to them, along with good use of money and system sustainability. How do we best resolve this? Don't know if anyone wants to come in on that. It's quite a big question, but I think it's an interesting one for us to discuss.
I'm happy to kick it off. It was a really good question from Martin, and I think there's one of the risks with prevention and the sort of crisis we face at the moment, that we purely focus on the savings we're making to the system, you know, cost avoidance, you know, and around prevention, and you don't actually then recognize the point around why we're really in this is about supporting people to lead good lives, to be in control and be recognized as contributing, connected citizens. And as the system becomes under more and more pressure, there's a risk that we just slip over to the right and just focus purely on cost avoidance, which isn't what we should be about. You know, the Care Act is about recognizing people as individuals, as citizens, and to be able to lead good lives, to have good health and well-being. It's not necessarily about savings to the system and cost avoidance. So it's certainly something that we need to recognise. And I think what came across in everybody's presentations was the value base across them all, around being person-centred, about seeing the person, seeing the whole person, the whole family, whole community, and recognising that's the important thing that we want to achieve. We want everybody to have good lives, and the value of having good relationships will support that, not being safe as a result of having services around you.
Harriet, can I chip in and follow on from what I knew we could trust Joe to start the ball rolling on that one. One of the things that we emphasise in research, which I think follows on from that, is that by starting from the point of talking to people about their lives and the context within which they came into support, it really gave us a good understanding of the bigger picture of what that overarching context is, and why some of the issues, the things that Kerry was picking up on, are triggers into a bigger problem where they feel they can't cope. And what really emerged out of that was themes around people who were grappling with transition into older age, grappling with having to live with a physical or mental health issue, or people who just experienced a sudden trauma in their lives that radically changed the context they were living in. And I think sometimes with the language of prevention, it sort of pushes that notion that we can stop some of these things, we can prevent them, and we have to show that we prevented it so they don't then need the service. You can't prevent getting older, much as we'd all love to. We are all going to go through that process. And it's rethinking that thing and saying, well, okay, if we can't prevent these things from happening, how do we make sure that actually they're in a position that are much better able to cope with the things that come their way in those stages? And how do we reach? To me, it's a case of reinterpreting what we're trying to capture. And this is why we've always struggled to measure it, because we're constantly trying to measure something we can't measure. Whereas if we start to rethink, what is it which we're doing? What is it that's happening? And how do we, Joe mentioned the notion that people are able to bounce back better. When they're facing a new challenge, are they better able to cope because of the things we put in place to support them? And I think if we start to channel that, the strengths we're helping them to build and shape, the things that we're pulling out from their own abilities, we get a much better notion of what prevention really does, and we can capture that in a really true, solid, measurable way.
Yes, I think as well, I've got a couple of thoughts on that in terms of it's probably more nuanced when we say prevention and reduce demand. what we mean initially, I think, is let's try and reduce the nature of the demand from our really high intensity, real high-end crisis point. So how do we then work as a system with people to do the right things to enable them to avoid that crisis, even if things are really tough for them? And then how do we reshape our services around that? And yes, for some people, hopefully, hopefully a lot of people it will be a temporary crisis point that they've hit. And with that help and support and time, they can get to a point, depending which way you look at the triangle of need, either higher or lower than the point at which they're at, which then creates space for those people who, as Kerry was saying, will have longer term issues, will need support going forwards, and it frees up the resource to do that, with the goal of helping people to live the best lives that they can. And I do think sometimes, and we've pulled ourselves up on this at Oldham, haven't we, about what do we mean when we say reduce demand? Because in some cases, we don't want all the demand to disappear. If people need, say, help with a health-related problem, we absolutely want them to be able to access that help early, rather than not be in the system until the point they appear at crisis, maybe at A&E. Mental health is a good example of that. The earlier people are engaged and can get some support, whether it's through IAPT or whatever, the better, for everybody. So I think you're right, it is more nuanced than I think we started out thinking, and we have very much changed our thinking around that and what we mean, and then what we do about that.
I wonder if the other area of nuance is also that it's not simply about reducing demands that are coming into the system, it's actually about working in a strengths-based way with people to enable them to be part of being a resource for others in their communities and to their communities. So it is much more nuanced than that simple dynamic of reducing demand and saving money. It's about creating, I don't know, just a better quality of life and community for people, which is absolutely essential to lifting them out of crisis.
And I think just to add to that, I think it's not just about reimagining and redefining how we see prevention, but how we see systems. We need to see people as key parts of systems. It's not just about working in a person-centred way. Those people, those citizens, those communities, they're a key part of that system. It's not a separate. And I think we need a real kind of culture change to kind of shift that thinking. We're definitely on a journey with that in York.
Fab. Thanks, Jenny. So there's loads of questions. I want to try and get through a few more if we can. So a few coming in around relationships with the voluntary community sector. So this was a question that came up during Joe and Jenny's talk about local area coordination. How can this approach be translated into commission? For example, to enable voluntary community sector service providers the freedom to work in this way. This is very similar to the way we work, but contractual reporting requirements of the local authority are very deficit-based and work against us. Got to throw those challenging questions in there.
Yeah, it's a good one, isn't it? And I think the experience we've had, and it relates to system change, is that I think one of the most powerful catalysts for system change in York has been sharing people's stories through local area coordination. That has really supported mindsets and cultures and behaviours within the system to change, and where we have a bit now a common narrative. So storytelling has become quite sort of infectious in York. It's just the way York does business to help inform system change and continuous improvement. But that language of asset-based community development and strength-based practice and working in a person-centered way, seeing the person as valuable and not vulnerable. Those are all parts of York's narrative now that cut across the whole system. So that's our colleagues in the voluntary and community sector using a similar narrative to ourselves. It's just the York way. And I think that then is reflected in what we are trying to commission, because we're wanting services and approaches that are to be commissioned to be more relational, to reflect relational centered practice, to reflect asset and strength-based working. I mean, I can remember a colleague saying to me from a voluntary sector organisation a few years back, do you mind if we use the term strength-based practice? Do you mind if we use the term walking alongside? And I'm saying, yeah, of course. That's what we want to encourage. We want the whole system to work in this way, all sectors to work in this way, and to see, you know, the outcomes that we want for people to be achieved through, you know, a genuine collaboration. You know, collaboration across the system has to be the golden thread for me. And I'll shut up because I'm probably rambling now.
And just to add to that, you know, the power of people's stories in that way, system change is one of the another integral part of the LAC model. And I think picking up on what Joe was saying about people loving their jobs, being allowed the freedom to work in this relational way, it's another reason why local area coordinators love their jobs, because they have that you know, they have that freedom to take people with them, people that they're walking alongside, and make tangible changes to the system. We're given that permission, not just given that permission, but encouraged to take those stories to those kind of strategic levels and take people with us. And one of the areas in York, I know in a lot of local authorities, housing is quite an impenetrable area in terms of changing, and we've made strides to change housing policy and practice to make it more relational and person-centred.
Thanks, Jenny. Yeah, I think there's another one actually that's come in about kind of collaboration from Nottinghamshire. Hi, Steve. Nice to see you in the chat. So in Nottinghamshire, local area coordinators work closely with neighbourhood coordinators and community organisers to kind of set up projects and connect with existing projects. Where does the speaker see community organising as fitting into this kind of bigger landscape of community building?
I'll chuck in something for first.
I was going to go again, but you go, John. So.
I was just going to pick up one of the things that we emphasise in the presentation and we emphasise in the work is, to me, it's that key of connecting the different parts of the process. We talk about people falling through the net by falling in those spaces in between the service system, the community, the individual. And when you look at when people talk about how they've ended up in a situation of crisis or struggle, it's because, like Kerry was saying, they didn't know where to go to. They felt they'd exhausted every route. There was not a connection. All these parts of the process, by better connecting, build that net around that process. They fill those spaces in between. And I think that's one of the things that we can really learn from this is understanding that the bits are there, often in place, but they just don't talk to each other and they don't engage with each other. Community organising is a really good way of starting to build that community embeddedness. And one of the things that LAC does very well is to look at where can we support community groups to grow, where can we support community capacity to increase. And that is important because, you know, there is a lot of areas where those things, especially during COVID-19, they got put on hold and they haven't come back. And there are holes in support that have just not been filled. And things like community organising, things like VCS support, things like local area coordination, are all parts of filling those spaces. And I think that's where we should be looking. How do we fill the spaces in between so we don't have those gaps?
Yeah, absolutely. There's some interesting questions coming in about kind of evidence base and how we prove prevention is a big problem, as we all know. Somebody has written, I think there needs to be more done around how we collect evidence. I think there are better ways to use technology and even how we use AI to analyse the different data collected. That's something we've been talking about recently as a team. We've tried evidencing with qualitative evidence, but this is impactful, but it's not necessarily conclusive in terms of that managing demand. And then this has come through the Jamboard in terms of wanting the network to help voluntary sector organisations to understand the value of evidence and data they already collect and how to enhance this. And then Mark has asked, in terms of the cost saving data, it'd be interesting to know how that has been seen by the purse holders, and has that translated, that cost saving data, into some more secure funding for the work? A few sort of thoughts and questions in there.
Jenny, do you want to go first with the cost saving data? Because that's your
Yeah, I can do. Yeah, so yeah, frustratingly, the answer is no, not yet. It hasn't translated into additional funding for us or more security. I think we're in a place where we felt there was a lot of pressure for us to gather that data, to develop these methodologies, and we're now trying to encourage our partners to listen to what we've found. It feels like the conversation is kind of moved on in a lot of ways in terms of budgets, and it's raised more questions as well about how we've arrived at these figures. So we're having to work through with senior leaders and our partners around explaining our methodology, explaining our working out around the data, and working with them to address some of the problems we know we have with the data. It's not complete. There are things that offset it. There are things that we need to kind of work through. So yeah, unfortunately, it's not translated into more secure funding, but we hope over time, as we work with partners around this, and I think what we would really like to do, listening to other presenters, particularly in Oldham, you know, you're looking at that kind of whole system approach to measuring prevention, to looking at costings, and I think we need to take partners on a journey with us to do that in York. We need their commitment and buy-in to share their data and triangulate it with the data that we've got, so we get a fuller picture.
I was just, sorry, Harriet, or somebody else. No, Rachel, you come in first. I can hold, don't worry.
I was just going to come in to say that, unfortunately, yeah, we've had similar experience when we've tried to cost the savings from preventative approaches. The example being conversation with adult social care, where we fairly conservatively demonstrated that we deflected demand from their front door and attached some cost to that, but ultimately the director at the time said, we can't take the money out, you know, even if we're convinced that you prevented that demand and prevented that cost, the cost of my service is still rising because of the wider demand. And I think so that's one thing, that even though he was convinced by that evidence, the budget challenge was too much to then still make a decision to move money. I think sometimes the other aspect of it is scale for me. So we're often able to demonstrate at small scale a particular impact or saving, but we're not sure what's the scale we would need to invest in order for that to impact on his bottom line. To a sufficient extent, and I think that question gets lost quite a lot in some of these conversations. So we'll celebrate the qualitative evidence, really helps us celebrate the small victories, but then we need to recognise the scale at which we need to do this to really make a difference.
And I think it's encouraging some of that longer term thinking, isn't it? It's challenging that short termism as well.
Yeah.
Amanda.
Yeah, I think we're related to this. You know, I wouldn't underestimate, you know, the trying to measure impacts across the system that is broader than the local authority system, you know, to make these inroads into prevention that we want to, and to measure consistently on that. And I do think there is an element of real challenge, more challenge back to local authorities around what degree of confidence are we willing to have? Because there's always the argument that we're not 100% sure that this intervention has created this effect because there are so many other causal factors or influences that there could be. So, well, we don't know that's going to work. And I think we need to question ourselves collectively about, well, are we ever really going to be able to isolate all the other causal factors and pinpoint exactly what has contributed and to what extent? I would argue the answer is probably not. And if that's not the case, what level of confidence are we happy to run with, generally within service or within the local authority or the bigger partnership, that says, you know what, we're convinced. We're convinced. We might not know the minute detail of this, but we can see that doing these things is having some kind of effect that is helping to take some of the heat out of the more intense demand. It is a challenge back for us, particularly when, as Rachel says, ultimately we have statutory services to provide that are absolutely on the edge of crisis, if not in crisis. And so it becomes hard, however much the amount of money is, if you haven't got that give in the finance and that give in the system to enable that to happen.
Yeah, absolutely.
I'd also say that there's kind of an added layer that we've started to experience, which is, you know, that, and I guess it's essentially around devolution. You know, at place we can have that collective narrative, we understand, etc. But we have the added layer of a regional. But, you know, how does our place prevention strategy fit into the regional strategy, fit into the national strategy? And it just adds layers of complexity because of the nuances of place and the agendas that they're fulfilling. And how do we, you know, we're often fitting square pegs into round holes. And so there's lots of toing and froing and, you know, bounce back in system, let alone with people out there in communities.
Yeah, that's such an important.
Just wanted to chip in, just to pull some of that together, because I think this is one of the reasons why we think there is real value in bringing different local authorities who are working on this challenge together. Because the frustration from our side of it is that you're all doing bits of the same thing, but you're not drawing on the research and the evidence that each other's finding to say, well, we can see there's evidence here that this is happening, or we can see that these people have done this part. So you can draw on existing evidence. You're all trying to create all of it yourselves. And I think you're never going to get there unless you start to say, in any academic term, we work within a space and we draw on the other evidence and we say, they've shown it. And with the LAC study, one of the key things we were able to do was a comparative study across all places. So we could say, look, that outcome is consistent, dependent on where it is, it's still happening. So we can draw that. And it's not down to one place saying, well, it's happening for us. And so people can't use that argument of, well, it might just be specific to you. So I think there's real benefit to starting to say, what is it everybody's doing? How can others learn from it? And how can then you utilize others' data as well as your own data to really start to build that universal, coherent evidence base? That's my rant for the day.
I'd just like to emphasise that it's actually bringing the sectors together, not just local authorities, but their voluntary and community sector partners, because only by joining our learning together can we really bottom this one, you know, and make sure that we actually can protect and invest in prevention, because we all know it works, but we've got to just be so much better at proving how and why. And then if we still don't get anywhere, which I have heard experiences of, then we have to push in different directions, I think, to actually completely reconfiguring about what is good enough, what, you know, from the basis of what Amanda was saying, you know, we're at that challenge point. So the point of the network and us wanting to bring people together and facilitate and create this is to actually start joining up the work we're doing and learn from each other. I'm also aware there's other networks that already exist. We need to connect into those and draw those in as well, because the last thing any of us can afford to do is to keep reinventing the wheel and fighting these battles alone, because we're so much more powerful if we join together, I think. Sorry, Harriet, I went on to a little bit.
I was just going to say, I'm really sorry if I didn't get to your question. There's so many. We've done our best to get through them. A few kind of little nuggets of wisdom that people have dropped in. Around that last point, someone said that we can build adult social care and voluntary sector partnerships like the NHS has, and share resources and funds, and accountability for a joined up approach. Mapping is really critical, from Raj. And there's also, on kind of the broader thinking around prevention, someone said, Ian has said that prevention in the system is about cost savings. Terminology is really important, so we're starting to talk about health creation instead. And there was a point as well about maybe there should be commissioning systems, local authorities rather than services. And do we need to think again about the Care Act principle to prevent people coming into services? So some kind of interesting thoughts for us to kind of finish with. I'm going to hand back over to Joe, who's going to close. Were you not expecting me to do that, Joe?
No, I am. Don't worry.
Okay, good.
So first of all, just to remind you, the Jamboard is there to put in ideas about what you think the network should do and how we should facilitate it. We're applying for research funding to NIHR. It's to actually adapt our tools to other approaches to second wave prevention, test out the cost consequence framework in local area coordination, and then adapt that and extend that to other preventative approaches. But fundamentally, it's to build and maintain and facilitate a network, bringing us all together to share our learning. So we're going to be putting that application in on the 26th of June. Ben and Katie will be in touch with you, because of data protection, we have to ask you to opt in to continue to work with us and for us to retain your details and be able to continue to contact you. I really hope you want that. Please do respond to it. We really want to make a difference. I'm fed up of academics sitting in ivory towers, not doing something useful for practice. We are not that kind of academics in our team, and we really want to work with you. We're keen to share our tools. We've got a whole gamut of them. They're being adapted and tested in different local authority locations. We would love to hear from you, so please do get in touch with us. Yeah, the mailing list, I've done that right. I think it's just thank yous now. Harriet, is that everything?
Yeah, just to say as well, we've started up a LinkedIn page, which we are hoping to kind of use as a bit of a digital space for kind of conversations going forward. So I'm just going to drop it into the chat right now, the link, so you can follow us on there if you're on there, and you can follow us on X as well. Yeah.
Thank you. Oh, John, do you want
just
to
very briefly to say as well, we will leave the Jamboard up and open for a few days. So if over the course of the next day or so you think, oh, I've thought of something that's really useful that I want to add in there, or if specifically you want to put who it is who's writing, because the Jamboard things allow you to post anonymously on a post-it. You could also just stick your name on the top if you wanted us to get in touch about anything specific. So please use those spaces to link in if you think of something later on.
So just finally then, thank you so much to our panel of speakers. Amazing presentations, really thought-provoking. Thank you for the time. I know how difficult it is in this current time. Thank you to everybody who's turned up to listen and to take part. We're delighted that it has had such a good impact and that so many people have been interested. Can I really thank Harriet, because this was her idea, this was her brainchild. She thought about it, she's worked endlessly, tirelessly with Ben and Katie to get the numbers together, to organise the whole thing, and thank you for chairing it so well, Harriet. It's been a really, really nice to work with you on this. Yeah, thanks to everybody, and we will be in touch. Bye, everybody.